Hang on. Hello guys, how are you? Hello guys, how are you? Right. So how are you all? Are you able to hear me? Meenakshi, hello, good evening. Playboy, good evening, Playboy. Miraj, good evening, Miraj. Saif, Shamim, good evening. Luckily, we are discussing very important topics today. We are directly entering into the bacteria today. Right. So is there anyone still waiting out there to tell me hi? United Videos, good evening. Good evening, Abjit. Good evening. Thank you. Good evening, Priyanshi. I'm fine, Saif. How are you? I'm fine. Doing great. Thank you. Thank you for asking. I'm fine. Fine. I'm fine. Miraj. Hi. Yes, Shweta. It covers that part also. And we will also be doing the questions. Okay. So most of these questions here are USMLE questions. So we should also cover everything in related with the next exam, which you are going to write. I'm fine, Mike. I'm fine. Thank you. Good evening. Even I have a lot of friends from Yemen. So I think, shall we start? Yeah. Shall we start, guys? So I hope you all have attended the class yesterday, right? So yesterday we discussed a lot of things, a lot of basics. We have discussed a lot of basics yesterday. So guys, one thing I just want to tell you is that microbiology, I know it is a dry subject. There are a lot of facts to remember. I agree that. But in context with your next exam, or if you are writing your PLAB exam, or in PLAB they don't ask you, leave it. If you are writing USMLE or if you are writing IFOM exam, whatever it is, they go conceptually. Okay. So the concept part has already started from last year. So everything you have to learn conceptually. What is the most common cause? What is the least common cause? What is the second most common? These things are gone now. I mean, they might be questions like that, but mostly now they are testing conceptually. And I'll take the entire microbiology conceptual and teach you. So every topic after we discuss, we shall be doing a set of questions as I've shown you now. Okay. So I promise you that you will do all these tough questions. These are really difficult questions. These are really difficult questions. So you will be doing all these difficult questions from the topics which we discussed today. So Meenakshi, thank you so much. Thank you. Dr. Farhat, good evening, Farhat. Soumyadeep, hello. Right. Gachangi is telling, let's start. So let's start. Ria Sardar, hi. Right. So let's start, guys. First of all, before I directly enter into the topic, I just want to classify these things. As I already told you, every microbiology class I'll basically classify and then I'll discuss the topic. So there is a bacteria called gram-positive bacteria. Okay, there is a bacteria called as gram-positive bacteria. Now, gram-positive bacteria are divided into three parts. There are some bacilli. I hope all of you know what is bacilli. Bacilli means rod-shaped bacteria. So bacilli come under gram-positive, foci come under gram-positive, and there are also some branching filaments. You know, yeast and all, right? Even they branch into filaments, right? So branching filaments, they also come under gram-positive. Okay, but our main discussion will be from today onwards regarding the bacilli. We shall finish up the bacilli, then jump into the cocci. So within the bacilli, there are some organisms which definitely need oxygen. Okay, there are some organisms which definitely need oxygen, and if there are conditions where there is no oxygen, they will die. In contrast to that, there are some organisms which don't need oxygen, which means if you are providing oxygen to them, they will die. So those organisms which need oxygen are aerobic organisms, which do not need the oxygen are anaerobic organisms. Anaerobic organisms. Okay. So I'm just grouping up a list, guys. So keep it in mind. Aerobic organisms are, for example, Listeria. I'm not writing all of them. Most important things I'm writing. Okay. Listeria, Bacillus. You know, Bacillus means Bacillus anthrax, Bacillus cereus, right? And Corynebacteria. Corynebacteria. Okay. Coming to anaerobic, we have got Clostridia, all the Clostridium species, and Propionibacteria. Propionibacteria. So what is my topic today? My topic of discussion will be mainly regarding the Clostridium. We shall be discussing as many Clostridial species as possible, and we shall also do the questions. Okay, so let's get started, guys. Let's get started. So the first important thing, the moment I put the heading, for example, Clostridium tetani, the first topic which I'll be discussing is Clostridium tetani. Okay, the moment I put the heading, few important things should come into your mind. First important thing from the graph which I have given is, this is a gram-positive bacteria, right? So this is a gram-positive bacteria. Second important thing is that, is it a bacilli or cocci? It is a bacilli. So it is a gram-positive bacillus. It's a gram-positive bacilli. And third important characteristic is that it is aerobic or anaerobic? It is anaerobic. So what I'll tell you is that, guys, instead of studying each bacteria, and within each bacteria studying gram-positive bacilli, anaerobic or aerobic, instead of that, if you look through a graph like this, if you practice this graph, I mean this chart, this would be really easy for you to crack the questions, believe me. Okay, right. First important thing, what shape is of Clostridium? All of you tell me, what is the shape of Clostridium? Med booster, hello. What is the shape of Clostridium, guys? Some defect in the sound? Is there any defect in the sound? Or is everything clear? Everything is fine, Ribi. Everything is fine. Fine. Very good. It is rod shaped. Obviously, it is rod shaped. I know. I mean, what is the special name that is given? If you look at the spores of Clostridia. Okay, tell me what is the shape of the spores of Clostridia? Yeah. Not spherical. So actually, let me teach you. Let me teach you this. It is not spherical. It is in this way. What is this? What is this shape, guys? What is the shape of Clostridial spores? Excellent, excellent, Saif, Shamim, excellent. Very good. This looks like a tennis racket shape. Tennis racket or drumstick shaped. Tennis racket or drumstick shape. Okay. So look here, look here. Look at the picture here, guys. Look at the picture here. This looks like a tennis racket or a drumstick shaped. So this is the picture of that. This is the picture of that. Okay. Now, let us enter into the clinical point. What is that white color thing in the center? I mean, what is the blue color thing which I have drawn in the center? I'll tell you in a minute. But before that, I just want to tell you that these pores are heat liable. Heat liable. These pores are chemically stable. Heat liable, chemically stable. Not only that, these pores can live for a long time. But anyways, keep that thing aside. The important thing is that these pores are heat liable and chemically stable. Now, what makes these pores heat liable and chemically stable? Can anyone from our previous classes tell that what makes these pores chemically stable and heat liable? Yes, I have discussed in the starting video of the microbiology. Yes. Anyone with any good answer? Soumyadeep, cell wall, no. Okay, fine. So look here, not cell membrane, Osama. Look here, the blue color thing which I've drawn in the center, this is nothing but called as dipicolinic acid. That is nothing but called as dipicolinic acid. Okay, this is nothing but called as dipicolinic acid. Dipicolinic acid is the one which is making the spore to live for a long time, right? The spore to be heat liable. It is making the spore heat stable, chemically stable, right? So if there is no dipicolinic acid, then the spores might die immediately because of all the unfavorable conditions. Okay, so this is an MCQ. Just keep this thing in mind. Okay, this is an MCQ. Just keep this thing in mind. Mystery school. Hi. Let us enter into the topic, guys. The first thing we have discussed was gram-positive bacillus, which is anaerobic. Shape is like a tennis racket. It has got dipicolinic acid in it, which is responsible for heat liability as well as chemical liability or stability. Right. Next important thing is that what are the risk factors? If, for example, if the spores have to enter into my body, or if I should get a Clostridium tetani infection, right, the tetanus basically, what are the risk factors? The first, second, and the three important risk factors. United videos, excellent. It is dipicolinic acid. Very good. So the three risk factors, the first risk factor all of you know, that is chronic wounds. Chronic wounds. The second risk factor will be any kind of trauma. Either it can be trauma in the hospital, the surgical trauma, or trauma outside. Okay. Third important thing would be lack of vaccination. If I am not vaccinated against diphtheria, then I am at a high risk of getting this infection. Lack of vaccination. Lack of vaccination. Okay. Which vaccine, I'll tell you at the end. Okay, when I'll tell you the part, I mean when I tell you the prevention part, that time I will tell you what is a vaccine that is responsible. Is that fine? Right. Fine. So look here, what type of hemolysis does this Clostridium tetani undergo? Can anyone tell what type of hemolysis does this Clostridium tetani undergo? Yeah. Anyone? Excellent, Kylin. Kylin COL is telling it is DPT vaccine. Perfect. Very good. I asked you what kind of hemolysis, right? There are three types of hemolysis, right? Alpha hemolysis, beta hemolysis, and gamma hemolysis. So what type of hemolysis does beta, Miraj Ahmed? Yes, you're right. Beta hemolysis. But one very important thing I want to tell you is that, all of you sit back and relax. Clostridium tetani undergoes alpha hemolysis. What is alpha hemolysis? Alpha hemolysis is also called as partial hemolysis. Okay. But look here. What will happen is that this Clostridium tetani is going to release three important toxins. Okay. Clostridium tetani will release three important toxins. Three important toxins. What are the three important toxins? One is called as tetanospasmin. One is called as tetanospasmin. Okay. And the next one is called as tetanolysin. Tetanolysin. And third one is called as non-spasmogenic toxin. Non-spasmogenic toxin. Vanilla, hi. So there are three types of toxins that are released: tetanospasmin, tetanolysin, and non-spasmogenic toxin. So now look here, guys. It is this toxin, tetanospasmin, is a very powerful toxin. You know how powerful it is? How powerful it is that last class I have already told you that you put a bacteria here. Surrounding that bacteria, you put 100 RBC. Surrounding that bacteria, you place 100 RBC. If this bacteria will release a toxin called alpha hemolysin, and alpha hemolysin cannot destroy all the 100 RBC, it can destroy only 50 RBC. That is the reason why you called it as partial hemolysis. But this tetanospasmin is so potent that it will destroy all the 100 RBC. So when it is destroying all the 100 RBC, then what hemolysis is it undergoing? It is undergoing beta hemolysis. So initially, Clostridium tetani, before releasing the spores, it will undergo alpha hemolysis, but later on, after releasing this tetanoplasmin, with the help of this tetanoplasmin, this will undergo beta hemolysis. Beta hemolysis. Did everyone understood whatever I've taught now? Yeah? Very good, Dr. Benedict. Very good, everyone. Right, let me give you a powerful box, guys. Very important box. Very important box. All of you have to keep in mind, because this is completely MCQ related. Definitely you're gonna get questions from this. Okay, very important. What is this important box? We have seen Clostridium tetani. We have seen Clostridium botulinum. Okay. Next, we have got Clostridium difficile. So all these are Clostridial species: Clostridium tetani, Botulinum difficile, and perfringens, right? Clostridium perfringens. All these are Clostridial species. Very important thing you need to keep in your mind, that Clostridium tetani causes tetanus. What does Clostridium botulinum cause? Anyone? What does Clostridium botulinum cause? Meenakshi Chauhan, botulism, but the real answer is not exactly botulism. Vanilla, GMC, you're perfect. Paralysis. Obviously, botulism is the answer, but most commonly, Clostridium botulinum causes paralysis. Okay? Paralysis. Miraj Ahmed, food poisoning, very good. Paralysis. Okay? There are 8 different types. There are 8 different types of Clostridium botulinum. Out of all these 8 different types, only one type will cause botulism. Only one type will cause food poisoning, but the remaining 7 types are going to cause paralysis. I will differentiate between Clostridium tetani and botulinum later on. I mean, in this video itself, right? So, but before that, Clostridium botulinum causes paralysis and botulism. You know, nowadays they're not putting botulism or food poisoning in the option, they're putting paralysis. Clostridium difficile causes PMC. What does PMC stand for? All of you will write in the comment. Then by then I'll go for the next one. Excellent. You are so fast, guys. Dayananda Patil, excellent. Pseudomembranous colitis. Pseudomembranous colitis. You know why I asked you? Because I don't know the spelling of pseudomembranous. That is why, so that at least if you comment, I'll write it down. Right? Clostridium perfringens. Clostridium perfringens causes gas gangrene. Clostridium perfringens causes gas gangrene. Okay? Did everyone understood this box here? Let us now directly enter into the pathogenesis. Very good. You understood the general properties of the bacteria. You understood the risk factors, how you gonna get it. You even understood what are the 3 toxins that are released. Very important. I will also show you the MCQs here. Very, very important. After this topic, we shall do the MCQs. And now I am going to teach you one very important thing. How does tetanus occur? It means I'm going to teach you the pathogenesis. All of you don't write anything. Sit back and relax. Just sit back and relax. Don't write anything. Right. So look here. All of you. We have got 2 neurons, guys. This is a neuron which you can see. Okay. This neuron is called as presynaptic neuron. Presynaptic neuron. Okay. This neuron basically, it releases a neurotransmitter called as inhibitory neurotransmitter. Either it can be GABA or it can be glycine. Whatever it is, it releases inhibitory neurotransmitter. It releases inhibitory neurotransmitter. Okay. So this is releasing inhibitory neurotransmitter. Very good, Osama Sheikh. Now we have got another neuron here. And the name of this neuron is alpha motor neuron. Alpha motor neuron. All of you should clear one thing in your mind, that alpha motor neuron is responsible for contraction of your muscle. Okay. So keep that thing in mind. Alpha motor neuron. Okay. This is responsible for muscle contraction. Muscle contraction. Okay. Now what I'm trying to teach you is that, normally in you and me, alpha motor neuron, all the time it fires. Alpha motor neuron is working 24/7 in you and me. It keeps on firing. It keeps on sending the electrical impulses. If it keeps on sending electrical impulses, then 24/7 my body will be in a contracted state, isn't it? Then why my body is not in a contracted state? Why is it in a neutral state? Because time to time, from the presynaptic neuron, inhibitory neurotransmitter is releasing, and this inhibitory neurotransmitter will inhibit that neuron. So whenever I want to contract, inhibitory neurotransmitter is not released and I can contract. Whenever I want to relax my muscles while sleeping, for example, inhibitory neurotransmitter is released, that will inhibit the alpha motor neuron. So this is the basic thing. That happens in you and me. Okay. United videos, definitely I'll upload this lecture, right? But I wanted you to be in the session because if you have any doubts, so that I could clarify it. Okay. This is the normal thing that happens in you and me, guys. But look here, I'm going to draw it in little bit detailed. Why? Because the entire pathogenesis is just based on these 2 pictures. So let me draw it with the alpha motor neuron with the blue color, right? So this will be alpha motor neuron. Okay. Now all of you don't comment anything, just look here. We have got some vesicles here. These are called as synaptic vesicles. Within these vesicles, we have got a neurotransmitter that is called as GABA, right? Someone has already told me, Osama Sheikh has already told me that it is GABA. Very good. So we have got something called GABA or glycine. You know, GABA and glycine, both of them are inhibitory neurotransmitters. They inhibit everything, right? But important thing to know is that on the surface of this neurotransmitters, you have got a molecule like this. On the surface of it, you have got a molecule like this. Okay, the name of the molecule is synaptobrevin. Synaptobrevin. The name of the molecule is synaptobrevin. Next, on the wall of the presynaptic neuron here, on the wall of this, you have got two channels like this. Okay, you have got two channels. Now these two channels are having some openings, guys. These two channels are having some openings like this. There are stick-like things that are located on these two channels, and this is called as syntaxin. Syntaxin. So synaptobrevin is on the vesicle, syntaxin is on the channel, on the gated channel. Now synaptobrevin and syntaxin, both of them are called as snare proteins. They are called as snare proteins. They are called as snare proteins. Okay. Now normally in you and me, Dayananda Patel, synaptobrevin means a stick-like thing that is located on the vesicle. You can see a vesicle here, a stick-like thing that is located on the vesicle is called, that protein is called as synaptobrevin. Now, in you and me, what happens is that whenever I wanted to relax my body, what will happen is that a lot of calcium will enter into my body. Right? You know what this calcium does? What this calcium does is that one calcium ion attaches to one stick, another calcium ion attaches to another stick. So both the calcium ions are positive charge. So positive will, what will happen? It will repel. So both these ionic channels, they will repel like this. So when they repel like this, how does the picture look is that this is how the picture looks when they repel. They are open now. When they are open now, the vesicle will come and fix inside, isn't it? The vesicle is gonna come and this vesicle will very happily fix inside. And once it fixes inside, it will start releasing that neurotransmitter called as GABA. Okay, and GABA will act on the alpha motor neuron and it will inhibit the alpha motor neuron. That is how my body muscles get relaxed. Did you understand this point? Before I go to the next one, did you understand this? Yeah. Fine. Now look what will happen. What will happen is that by chance, for example, let us say I'm playing outside in the sand, in the desert or whatever it is. Suddenly I fell down. Now I had a very bad wound on my leg. Let us say I had a very bad injury on my leg. Now I went to home, but I did not wash it for, let us say, 4 or 5 hours. Okay. Later on in the night time, while I take the bath, I washed it. By that time, the Clostridium tetani has entered into my body. Now, what will Clostridium tetani do is that it will release 3 important toxins. One is called as tetano, spasmin, lysin, and non-spasmogenic. Now, what will happen is that tetanospasmin will come slowly towards this synaptic cleft. Okay. Tetanospasmin will come here, and what it will do is that this tetanospasmin will go and completely destroy the snare proteins. What are the snare proteins? Synaptobrevin, syntaxin. It will destroy the snare proteins. When snare proteins are destroyed, do you think the vesicle will come and fix to the channel there? It cannot fix because there is no syntaxin, there is no synaptobrevin. It cannot fix. So when it cannot fix, do you think GABA will be released? This is GABA. GABA will be released? No. If GABA is not released, then alpha motor neuron is not under any inhibitory control. So alpha motor neuron, as usually, it keeps on firing and your muscles of the body gets contracted like this. That is the reason why in tetanus you see patients with sustained muscle contraction, continuous muscle contraction. Okay. So an example of sustained muscle contraction is tetanus. You understood the pathogenesis now? Sustained muscle contraction. You've got sustained muscle contraction. How snare proteins will get inhibited by tetany bacteria? So I told you tetany bacteria will release tetanospasmin, and this tetanospasmin will inhibit the snare proteins. How will it inhibit? Means it will go and destroy that. Okay, it is a spasmin, right? It is a lytic toxin. It will lysis, it will break down them. When it will break down them, obviously the things go wrong. Okay, okay, Dayanand, right? So the question is that, sir, in Clostridium tetani, I will have paralysis. In Clostridium botulinum also, you just told me, in Clostridium botulinum also, you told me paralysis. Then how will I differentiate, sir, between Clostridium tetani as well as Clostridium botulinum is that, in case of Clostridium tetani, I will have paralysis that is called as spastic paralysis. Spastic paralysis. Now, what is meant by spastic? What is meant by flaccid? I will tell you in the next topic. Next topic, you will understand what is flaccid, what is spastic. Okay. So, but for now, just trust me that Clostridium tetani is going to undergo a type of paralysis. I mean, it will make you to undergo a type of paralysis called as spastic paralysis. Okay. So, yes, Benedict has already told the answer, but anyways, I'll explain you. Second important thing, as it is contracting your muscles a lot, it will even contract your buccal muscles. So when your buccal muscles are contracted, the patient's face looks like this. You see, this is called as rhizus sardonicus. Rhizus sardonicus. Third important thing is that the patient's jaw muscles will be contracted and he cannot open the mouth. So the jaw will be locked. This is called as lock jaw, or otherwise called as trismus. Locked jaw or trismus. Very good, Osama. Perfect. Fourth important thing is that, look here, all the muscles which you can see here on my body are flexors. All the muscles on my back, the spine muscles, all of them are extensors. They are called as spinal extensors. So when all my spinal extensors will contract, what will happen is that my body is stretched in this way. My body is stretched in this way. So this is called as opisthotonous position. Opisthotonous position. Okay, this is called opisthotonous position. Now look at the pictures, guys. Look at the pictures. Now this picture which you can see here, this picture is of rhizus sardonicus. All of you listen to the topic carefully, because after this we are about to do the questions. Rhizus sardonicus. Okay. The next important picture will be this thing. Dayananda Patil, even flexors also will contract. You look at this picture. That is the reason why patient hands are flexed. Right? So even flexors will contract, but the spinal, in this picture over here, the spinal extensors are contracting, which will give this type of position which you can see. This is called as opisthotonous position. Okay, this is called as opisthotonous position. Right. And the next picture I wanted to show you, lockjaw. I don't have lockjaw, but these two are the things, rhizorius and opisthotonous position. Right? Right, guys. Now, another important thing is that while delivering a baby, during parturition, while delivering a baby, let us say there was cesarean section, or okay, let us say there is a normal delivery. So after the normal delivery, what you need to do is that this is the umbilical cord, right? So you need to put a clamp here. You need to put a clamp here with the help of artery forceps. You need to put a clamp. And cut down the umbilical cord. Now, the artery forceps, whatever you are using, if they are not properly sterilized, where do you sterilize this? You sterilize all the instruments in an autoclave. Okay, so in autoclave the temperature used is different, but if Clostridium tetani spores should not enter into your body, you have to sterilize anything, whatever it is. you have to sterilize those instruments for 100 degrees centigrade for about 20 minutes. So here we got another MCQ that at what temperature are the spores gonna die? The spores gonna die at 100 degrees centigrade for 20 minutes. If you have not provided sufficient temperature, no proper sterilization, then the spores will enter into the umbilical cord. Then the umbilical cord will be damaged, umbilical cord will be inflamed. From the umbilical cord, it will enter into the baby. Once it enters into the baby, the type of tetany we get in the baby is called as neonatal tetanus. Okay. So look at this picture, guys. You will get a complete understanding. Look at this umbilical cord here. This is an infected umbilical stump. This is an infected umbilical stump. Okay, clear? So whenever you are unsterilizing the stools, that is when you get neonatal tetanus. Neonatal tetanus. Clear, everyone? So obviously there are three different types of vaccines you give to prevent this condition. One is called as DTaP vaccine. DTaP vaccine. DTaP stands for diphtheria, tetanus, and pertussis. You know, pertussis means whooping cough, right? Pertussis is whooping cough. Next, you also give Tdap vaccine. Now, when do you give Tdap vaccine? By 10 years, by 3 to 4 years or 4 to 6 years, you have to complete this DTaP vaccine. After that, this Tdap vaccine is a booster dose. It is a booster dose. When do you give booster dose? You give booster dose at 11 to 12 years of age. Okay? 11 to 12 years of age. Next, you give TD vaccine. TD vaccine is a third vaccine that you give at 10 years of age. I mean at 10 years interval. So every 10-year interval you will be giving this. Okay, so these are the three vaccines. And here someone asked me about rigor mortis. Rigor mortis is completely different, guys. Okay, rigor mortis, in the dead bodies you see the rigor mortis. Now how this happens is that when you study forensic, okay, I'm not discussing forensic now, but when you study forensic, there you will study rule of 12. Okay, rule of 6, I think. Yeah, rule of 6 or rule of 12. Rule of 12 it is. What is this rule of 12 is that it will take 12 hours for the body to undergo contraction. To undergo rigor mortis, it will take 12 hours. Okay. The next 12 hours, the contraction is maintained. And in the next 12 hours, the body contraction is lost. Again, the body will become normal. So that is called as rule of 12 in forensic, right? But anyways, we are not discussing that now. Let us discuss the treatment part. Treatment part is that this is the toxin, so I need to give an antitoxin, and that antitoxin will be tetanus antitoxin. What is a tetanus antitoxin? It is tetanus antibody or immunoglobulin, okay, which is an antitoxin, You know what does it do? So far we have discussed three types of toxins, right? Out of that, which is the notorious one? Tetanospasmin. So this antibody will go bind to the tetanospasmin and it will not let tetanospasmin to undergo any other notorious thing in your body. Okay? It means what I'm trying to tell you is it will neutralize tetanospasmin. It will neutralize this tetanospasmin. So what will it do? It will neutralize this tetanospasmin. I hope you understood. And the regular antibiotics which we give, that is metrozil. Metrozil means metronidazole. And third important thing is that we give such a drug. Remember guys, we give such a drug. What the drug will do is that the drug will try maximum to accumulate all the GABA. I mean, GABA is not released, I agree, but some amount of GABA will be released, obviously. Hypothetically speaking, it is not released here, but practically speaking, some amount of GABA will be released. What this drug will do is that it will take up all that GABA, keep it with itself and go and activate the alpha motor neuron and inhibit the alpha motor neuron. Okay, so whatever GABA is there in the body, it will collect all the GABA and throw it on the alpha motor neuron and inhibit it. So that drug is called as benzodiazepine. Benzodiazepam. Okay, so what is this benzodiazepam? To prevent the muscle spasm. To prevent muscle spasm. Now someone asked me, sir, will a patient of Clostridium tetani die? Yes, he will die, because muscles are everywhere in your body. Even for breathing also you need muscles, respiratory muscles. What if respiratory muscles are contracted, if they are not relaxed? Now don't think if respiratory muscles are contracted, patient will take continuously air inside and it is very good for the patient. No. If respiratory muscles are contracted, patient cannot take air inside properly. He cannot exhale it, right? So the muscles won't let the patient to take the air inside. So patient will undergo respiratory compromise and patient will die immediately. Okay. So what are the complications if you see? Spasm of respiratory muscle. He will go into respiratory failure. Okay. And sometimes it can also be like this, that these patients, yes, we can give calcium gluconate. And sometimes it will also happen like this, that these patients can aspirate some food materials, okay, and can have aspiration pneumonia. Aspiration pneumonia. So far what we have discussed, guys, we have discussed that this is a gram-positive rod, the bacillus, tennis racket-shaped spores, dipicolinic acid inside, heat stable, right, chemically stable. It has got 3 important toxins: tetanospasmin, tetanolysin, spasmolysin, and non-spasmogenic toxin. Out of all these 3, tetanospasmin is the most potent toxin. It can convert alpha hemolysis to beta hemolysis. It can even break down the snare proteins. As a result, GABA cannot be released. What are the risk factors? Injury, lack of vaccination, all of these will be the risk factors. What will be the symptoms? I already told you the symptoms. Patient will have rhizus sartorius. These symptoms can be given in the question. Rhizus sartorius, lockjaw and opisthothronous position. Okay, this can happen to a neonate and you call it as neonatal paralysis or neonatal tetanus. Okay, if you understood this, we will go do the questions. Yeah, all of you. Very good, Osama Sheikh. Fine. So let us do the questions now. You will answer me. You will answer me this. All of you look. I want answers from the remaining students. Okay. I want the answers from the remaining students. A 6-year-old boy who recently Dayananda Patil, you will not keep ventilator immediately. Even if you keep ventilator, you basically keep ventilator. Why? Because patient is not able to take air inside. So you put the ventilator and you mechanically you're sending the air inside. But even ventilator will not work, Dayanand. So what you do is that you intubate the patient. Okay. So intubate the patient and attach it to a ventilator. So that would help the patient, I think. So a 6-year-old boy who recently immigrated to the United States is brought to the emergency department by his mother. His mother states that the boy had deep cut several days. Look here, he was having a deep cut several days ago, which she thoroughly washed and bandaged at home. Fine. He has now been having severe muscle spasms. Few days ago he was having deep cuts, now he is having severe muscle spasms. When you examine the boy, you note the findings in the A. Whatever finding, he is not crying. The boy is not crying. What is the position of the mouth the boy is exhibiting there? Very good, Dr. Bandit. Rises. It is rises sartonicus. Which of the following best describes the mechanism? All of you. Priyanshi, you're right. Meeraj Ahmad, right. Osama Sheikh, Vanilla. Perfect. So, did we discuss anything like inactivation of elongation factor? No. We did not discuss increase in cyclic AMP. No. Destruction of protein leading to inhibition of neurotransmitter release. Destruction of what protein? Anyone? Destruction of what protein, guys? Shweta N, you're perfectly right. It is called green phase. Green phase. Shweta, you're right. Very good, Dr. Benedict. It is snare proteins. Excellent. Meeraj Ahmed, excellent. Snare proteins. Okay. Snare proteins. Iram Azhar, perfect. Destruction of cell membranes, no. Massive release of cytokines, no. If there is massive release of cytokines, you know what will happen? Patient will have severe fever. Okay, severe fever. Okay. A 71-year-old male was brought to the emergency room by his caretaker and presents with difficulty breathing, muscle rigidity. Where is the muscle rigidity? In the face, in the neck, in the back, in the upper extremities. And patient was having what? Profuse sweating. The intern notes a large wound on his head. You see, there is a large, he has a history of large wound on his head. Right. The intern performs a quick physical exam and observes increased reflexes. The patient was intubated. You see, the patient was intubated here. And he was given diazepam for muscle to release the muscle spasms, antibiotic like metronidazole, we discussed it, and immunoglobulins, we also discussed it. After the blood work came back, which of the following neurotransmitters is affected? Anyone? Anyone? Yeah. Which neurotransmitter might have been affected here, guys? Perfect. Meeraj Ahmed, perfect. Meenakshi, excellent. Excellent, guys. Kylin COL, perfect. It is glycine. So it can also be, even if they give GABA also, I'll put the answer as GABA. Okay, even if they give GABA, then definitely I will put the answer as GABA. All right, all of you, Dr. Shweta, perfect. Dr. Bentik, perfect. Let us switch on to the next question. A 1-week-old infant, now look at this interesting question. A 1-week-old infant that was birthed at home is rushed to the emergency room by his parents. You see, the birth was, where did the birth happen? At the home. His parents are recent immigrants, they don't speak English. Through a translator, the child's parents say that during play with the infant became rigid and his mouth locked up. The child is having any kind of dental infection. You see, 1-week-old infant, do you think he will have any kind of teeth inside his body? Infection of foot ulcer, colon, intrauterine infection? No. Excellent. Kylin, Jilan Basha, perfect. You guys are perfect. So, patient was having infection of the umbilical stump, right? Because the delivery happened where? The delivery has happened at the home. In the home, everything is unsterile, right? Everything is unsterile. So obviously, you can expect these things. Joshu Gawai, perfect, perfect, perfect. Let us discuss another topic called Clostridium botulinum, and then we shall do the remaining questions. And by the way, these questions were previously asked in your USMLE, okay, and such type of questions these are previously asked in USMLE, and such type of questions can be expected in the next exams, because next clinical, keep that thing in mind. Okay, so I'm really happy that you all answered before I read the question itself. Thank you, guys. Right. Okay. GABA, because thank you, Dr. Bentek. Thank you so much. Right. The next topic, Clostridium botulinum. Don't worry, there won't be much differences. There will be only few differences. Okay. Clostridium botulinum. Now, in Clostridium botulinum also, is it a gram-positive organism or gram-negative? All the Clostridium species gram-positive. So, gram-positive. It is a cocci or it is a rod-shaped bacteria. It is a rod-shaped bacteria. Second important thing, it is an aerobe or anaerobe. We have discussed these under anaerobic organisms. You know one thing? I have told this in the starting, but I don't know how many of you paid attention, but I'm telling you again, aerobic organisms, you don't provide oxygen, they will die. Everyone know. But for anaerobic organisms, if you provide oxygen, they will die. If you provide oxygen, they will die. Okay. So, coming to the spores. Spores of Clostridium tetani, we have discussed. Spores of Clostridium botulinum, we will discuss. Spores of Clostridium difficile and spores of Clostridium perfringens. Look here very carefully. In Clostridium tetani, if you look at the spore, I have already told you that the spore is like this. So this is a tennis racket shaped spore. Okay, tennis racket shaped spore. Now, the spore is present on the top. So can I call it as terminal spore? Can I call it as terminal spore? Yeah, I can call it as terminal spore. But if you look at the spores of Clostridium botulinum difficile and perfringens, if you look at the spores will be like this. Just below the terminal part, just below the head. It means, can I call it as subterminal? Can I call it as subterminal? Yeah. So one is terminal spore, another one is Gilan, perfect Gilan, very good. Subterminal spores. So why are you telling this? Is it really important? Yes, it is really important, because if they give you a very lengthy question and put a simple point that under the microscope the spores found to be subterminal, then first important point which will go away, first important option which will go away is Clostridium tetani. Okay, you can filter out one option, and definitely they will give you Clostridium tetani in the option. Right. Now, look at this picture. Look at this picture, guys. Look at this part here. Look at this. Where is the spore? The spore is subterminal. And where is the spore here? It is terminal. And the other one is subterminal. So here it would be terminal. Here it will be subterminal. Okay, subterminal. Simple thing. Right. I have already told you that Clostridium botulinum. I have already told you that this particular Clostridium botulinum is gonna release a toxin, and that toxin is called as botulinum exotoxin. Botulinum exotoxin. And obviously, if a toxin has to survive, it should be heat stable. Because of what? Because of dipicolinic acid. Dayananda is asking, which species of Clostridium is more pathogenic? Dayananda, I'll tell you in a minute which species is more pathogenic, right? So, coming to Clostridium botulinum, obviously it is heat stable. Now, how many types of Clostridium botulinum exotoxins are present? How many types of these exotoxins are present? There are 8 types. What are these 8 types of exotoxins? A, B, C1, C2, D, E, F, G. Okay, there are completely 8 different types. Meenakshi, perfect. There are 8 different types of toxins, right? Out of these 8 different types of toxins, C2 is the one which causes food poisoning. C2 is the one which causes food poisoning, and all the remaining will cause neurotoxicity. All the remaining are neurotoxic. This is a very, very important question. Very, 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 very important question, guys. Which strains, which types of this Clostridium are neurotoxic? Only the remaining all types except C2 are neurotoxic. Whereas what is C2? C2 is the one which causes the food poisoning. Okay, C2 is the one which causes the food poisoning. Clear, everyone? Now you might get a doubt. Okay, so I'm eating the food that is containing Clostridium botulinum. So how much concentration, what is the dose I need for this Clostridium botulinum to affect my body? So the lethal dose which you need is around 1 to 2 micrograms. Lethal dose is around 1 to 2 micrograms. Okay, fine. So you understood this. As usual, previous topic we have discussed the general properties, then we have discussed the risk factors. Now also we have discussed the general properties. Now we'll be discussing the risk factors. Right? So the first important thing, for example, if you are a student in abroad, right, you will be lazy enough to cook the food. So when you will be lazy enough to cook the food, you basically bring canned foods. Okay, you basically will eat canned foods, or you will also eat processed foods or canned foods, because processed foods or canned foods, they have got very good concentration of this botulinum exotoxin. Okay, next important thing, for example, if you are ingesting raw honey, ingestion of raw honey, you know, for children, ingestion of raw honey, you know, for the children, for the neonates, you basically feed raw honey. Okay, you basically feed raw honey for the neonates, and don't underestimate this point. Okay, very, very important point. Third important thing is called as contaminated wounds. So you already told me contaminated wounds will cause Clostridium tetani, but now I'm telling you contaminated wounds will also cause Clostridium botulinum. Okay, it will also cause Clostridium botulinum. Out of all these 3 risk factors, can anyone tell me which is the most common risk factor? Yeah, out of all these 3, anyone tell me 1, 2, 3, which is the most common risk factor? Yes, Meenakshi Chauhan, Dayananda Patil. Everyone is telling canned foods. Jilan Basha, very good. Joshua Gawai, very good. Excellent, guys, excellent. Now you are excellent enough to tell the wrong answer, but the most common cause of Clostridium botulinum will be your ingestion of raw honey. Ingestion of raw honey is said to be the most common cause of Clostridium botulinum. Now this is a simple point simple point which they ask you in the exams and you would put it wrong, right? You see how many students they filtered here. Yeah, now I'm asking you, most common cause of Clostridium botulinum in adults. In adults, it will be canned foods, I agree. But overall, the most common cause, including children, the neonates, and the adults, overall, it would be ingestion of raw honey. Okay, so keep that thing in mind. Keep that thing in mind. No, Dr. Shweta, for adults too, it would be canned foods. Obviously, not only adults or not only children, even if a child is eating, even if a neonate, right, a neonate is just now born, you went into the supermarket, bought canned food and try to feed him, he will get this type of infection. I mean, basically they don't eat canned foods. But in adults, if I ask you most common, it will be option 1. In neonates, if I ask you, overall, if I ask you the most common, it will be option 2. Okay. Particularly neonates, if I ask you the most common, again, it will be option 2. Okay. Now, I hope, yeah, Sambhav Avasti, she is right. Oh, yeah, yes, honey is fed. Yeah, honey is fed mostly to break breastfeeding. You're right. You're right. What should we do for preventing it? I'll tell you at the end. Okay, prevention, I'll tell you at the end. Let us first discuss the topic and then the pathogenesis part. Then I'll tell you the prevention. Okay. Now you'll clearly understand whatever I told you guys. There are 3 types of botulism. You know, there are 3 types of botulism. Okay. Now 3 types of botulism are, what are these 3 types? I actually, Osama Sheikh, I don't know Dabur honey, because Dabur honey, I think it is not raw honey, right? It is filtered honey, right? So I'm not sure, but anyways, what I think is Dabur honey is filtered honey, so nothing would happen with that, right? So anyways, botulism is of 3 types. See, they won't ask you that difficult questions, guys. Don't worry. They don't ask you that difficult questions. Don't worry. So botulism is of 3 different types, guys. What are these 3 different types? I'm writing it to avoid your confusion. In the first type, all of you should listen now. Stop commenting. All of you listen here. Right. So look here. Now there is a food, a cup of food. Now on that food, you have a very beautiful botulinum exotoxin sitting on there. You didn't knew this. Okay. So this is B. B stands for botulinum exotoxin. Okay. Botulinum exotoxin. Now this food, when you ingest it, after 12 to 36 hours, after 12 to 36 hours, the symptoms will appear. This is very important timing. Keep this thing in mind. After 12 to 36 hours, the symptoms appear. Now, this type of botulism is called as, come on, stop commenting here now. Dessert food, right? Everything we shall eat after the class. Don't worry about that. Right. So this type of botulism, you call it as classic form of botulism. You call it as classic form of botulism, or you can also call it as adult botulism. Why do you call it as adult botulism? Because such type of botulism, whereby you ingest the food after 12 to 36 hours, you go to the hospital with severe symptoms. So this is basically seen in the adults, so it is called adult type of botulism. Next important thing, there is something called infantile botulism. Infantile botulism. Now, what is infantile botulism? Infantile botulism is if you are ingesting raw honey, not you, if the infant is ingesting raw honey, what will happen is that now within the raw honey, there are spores. Now the spores will enter into your body. And from there, the spores will enter into the large intestine. And from there, the spores release exotoxin. Look here carefully. Look here carefully. In adult form, already the exotoxin is on the food. You're directly taking the exotoxin inside. But in case of infantile botulism, there is no exotoxin in the honey. What is there? There are spores in the honey. You ingest that spores. Spores will go to your large intestine. Spores will break down. It will release the exotoxin. And this exotoxin will colonize there. And it will affect the baby, leading to infantile botulism. And raw honey is the most common cause of infantile botulism. Raw honey is the most common causative agent for infantile botulism. And remember this thing, where do the spores enter? Where do the spores colonize? Spores colonize in the large intestine. Spores colonize in the large intestine. Okay. And the last type of botulism which we have is Wound botulism. Wound botulism, that is because of contaminated wounds. Contaminated wounds. So, yes, Sambhav, you are right. Late occurrence of the symptoms. Why? Because first spores have to go. Spores have to break down. It should release the toxin. Toxin should divide and toxin should affect. It will happen late. But in classic form, you're directly taking toxin inside. So it would take around 12 to 36 hours for the symptoms to appear. Now I'm writing a set of questions, guys. Keep this thing in mind. Keep this thing in mind. The most common type of botulism. The most common type of botulism will always be infantile botulism. Infantile botulism. Let me tell you one more thing. Let me tell you one more thing. The rarest type of botulism. Rarest type of botulism. Anyone know what is the rarest type of botulism? Excellent, Dr. Bentek. It is wound botulism. Wound botulism is the rarest type. Next important question. Most common causative agent of infantile botulism. All of you, most common causative agent of infantile botulism? Yes? Anjana Paul, you're right. Raw honey, perfect. Raw honey. Raw honey, very good. Very good, raw honey. Next important thing. Most common cause of not most common cause. Most commonly, which group of individuals are affected in case of classic botulism? Which group of individuals? Obviously, the answer will be the adults. Adults will be the answer. Okay. So, in classic botulism, you are taking what? In classic botulism, very good. All your answers I'm watching, they're perfect. Very good. In classic botulism, what do I see? In classic botulism, there will be exotoxin ingestion. Whereas in case of infantile botulism, spore ingestion. Spore ingestion. So these 2 points are very, very, very important, my dear students. Very good. Very good, very good, very good. Perfect. After this topic, I'll give you a break, okay? Let us now discuss the pathogenesis. All of you, sit back and relax. Don't write anything. All of you sit back, relax. Right. First of all of you sit back. Come on. Don't write anything. First of all, look here. You are ingesting it. Anything you are ingesting it. So I have to draw stomach. This is your beautiful stomach. Okay. Next. Here comes your beautiful blood vessel. You have to thank your body parts, you know. If you don't thank, they will turn up to screw you. So this is your presynaptic neuron. Okay. Now, then where is the postsynaptic? Okay, I'll draw. This is a postsynaptic neuron. Clear? Right. Important thing that on the surface of the stomach, I have got these projections. These projections which are located on the surface of the stomach, they are called as gastric rugae or the mucosal cells. We have got mucosal cells also there. Okay. Now, what basically happens is that whenever I ingest, let us say I have eaten the food. When I eat the food, directly I'm taking the toxin inside, and that toxin is called as exotoxin, right? So that exotoxin has got 2 components. So this is called as A component and this is called as B component. So what are these 2 components? This is called as A subunit, this is called as B subunit. So both of these subunits together form the exotoxin. Okay, fine. So what's next? What's next is that this A and B subunit, both of them, they cross the intestine. They cross in the sense that the intestine won't open the doors. They will damage the intestine. Okay, these toxins, they will damage the intestine like this and then enter into the vascular system. I mean your vascular compartment. So it will enter into the blood vessel there. It will enter into the circulation. A subunit and B subunit. And from the circulation, what will happen is that these two subunits, they will go directly and enter into the presynaptic neuron. They will enter into what? Presynaptic neuron. So this is your A subunit and this is your B subunit. Both of them have entered into the presynaptic neuron. Out of A and B, which is very powerful is the A subunit. B subunit will just, it is like a carry bag. It will carry the A subunit. Okay, it will carry the A subunit. Now what will happen? Look, all of you know the same story. We have got vesicles here, but this time in this vesicles we don't have inhibitory neurotransmitter. Rather, we have got excitatory neurotransmitter or activatory neurotransmitter, and that is what is called as acetylcholine. Right? Acetyl-CoA and choline, they join together to form acetylcholine. Same story. Acetylcholine vesicle is also having a molecule here. What is this molecule name? What should be this molecule named, guys? Previously I told you. Perfect, Jilan Basha. Vanilla, excellent guys, you are excellent. So this molecule is named as synaptobrevin. This molecule is named as SYB. I will write it as SYB. Okay, this molecule is named as synaptobrevin. And next important thing is that, very good, all of you right, Shweta, and you're also right. And the next important thing is that here also we have got some molecule that this is called as syntaxin. All of you know that. Syntaxin. This is called syntaxin molecule. Syntaxin molecule. One is synaptobrevin, another one is syntaxin molecule. Now what will happen is that, look here very carefully. Very, very carefully. Now this A subunit, whatever is there, right? This A subunit, whatever is there, look here. This A subunit is moving, and it will damage this synaptobrevin. It will damage this syntaxin, and finally this A subunit will come and sit here. Okay, so what has it done? It has damaged the synaptobrevin, it has damaged the syntaxin. So when synaptobrevin and syntaxin are damaged, do you think acetylcholine will be released? No, there will be no release of acetylcholine. But what is the normal function of acetylcholine? Acetylcholine will act on this neuron and it will contract the neuron. Acetylcholine will act on the neuron and it will fire the neuron. It will activate the neuron so that the muscle gets contracted. Acetylcholine is responsible for your muscle contraction. So if acetylcholine is not released, do you think the muscle will be contracted? No, the muscle will not be contracted. So when the muscle is not contracted, when there is no contraction, what will happen? This will lead to paralysis. Okay, this will lead to paralysis. Now wait a minute. Previously in Clostridium tetani also, you told me paralysis. Here also you are telling me paralysis. Then what kind of paralysis are you talking about? There, the paralysis happened because the muscles have been contracted so tightly. That is why you call it as spastic paralysis. Spasticity means tight contraction of muscles. It's called spasticity. Here, the muscle is not getting contracted. So the limbs will be so weak like this. He can't even raise his hand. They will droop down like this. The eyelids will droop down. The facial muscles will droop down like this. This is called as weak paralysis or drooping paralysis, or you can also call it as flaccid paralysis. So this type of paralysis is called as flaccid paralysis or floppy paralysis. Floppy paralysis. Very good, Osama. It is floppy paralysis. A and B subunit are together called as exotoxin. Meenakshi Chauhan. Okay. So Right now, I can make a difference, guys. I can make a difference that spastic paralysis, very, very important, guys. Spastic paralysis, I see in case of Clostridium tetani and flaccid paralysis, I see in case of Clostridium botulinum. Okay, so these 2 points are very, 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 very important. Yes, Shweta, and I'll repeat it again for you. So what I was telling you is that in Clostridium tetani, I told you that the muscle is in a sustained contracted state. That is also called paralysis. But as the muscle is continuously in a contracted state, you call it a spastic paralysis. But here as you can see, acetylcholine is not released. If acetylcholine is not released, then there is no contraction of muscle. When there is no contraction of muscle, the muscles are all the time relaxed. They are weak all the time. They are floppy like this, floppy all the time. That is why you call this as flaccid paralysis or weak paralysis. So tetany causes spastic paralysis, botulinum causes flaccid paralysis. Am I clear now? Yeah. So another important thing, guys. So whenever you see floppy or flaccid paralysis, if this same floppy paralysis happens in a neonate, it happens in a small baby. Floppy paralysis, if it happens in a small baby after ingestion of honey, do you think the baby will be fine? No. All the muscles in the baby, they become weak. The baby drools down like this. This is called as floppy baby syndrome. What is this called? This is called as floppy baby syndrome. Floppy baby syndrome is seen in Clostridium botulinum. Pathogenesis, floppy baby syndrome is very good. Pathogenesis is Shweta, you ingested the toxin. Toxin is consisting of A and B subunit. It will damage your intestinal wall. Why I'm stressing that it will damage? Because patient will also have intestinal symptoms. I will tell you. It will damage the intestinal wall, enter into the blood circulation. From there, it will enter into the presynaptic neuron. In the presynaptic neuron, this subunit A, whatever is there, it will go and damage synaptobrevin and syntexin. So what will happen? Acetylcholine cannot fuse and it won't release ACH. And you know the rest of the story. Right? Right. Now, Sambhav, you are perfectly right. B subunit, that's what I told you. B subunit is the carry bag. It will carry the A subunit. Right. Anyways. Look here. You might get a doubt that you told me that in Clostridium, Vaibhavi Singh came here with a very beautiful way to remember. She told B binds A under. Under means coming inside. Okay. Yeah, very good. You're right. B is useful for binding and A enters everywhere. You're perfectly right. Right. Fine. You might get a doubt that I have studied so deeply in one book telling that Clostridium botulinum will cause flaccid paralysis. But I have also studied that Guillain-Barré syndrome. You know Guillain-Barré syndrome? Guillain-Barré syndrome will also cause flaccid paralysis. Then can you please tell me how to differentiate a patient of Clostridium botulinum infection with a patient of Guillain-Barré? Look here. In Clostridium botulinum, patient will have flaccid paralysis, right? I told you patient will have flaccid paralysis. But this type of flaccid paralysis is also called as descending paralysis. Descending paralysis means the paralysis will start in the cranial nerves. From the cranial nerves, the paralysis will come down to the upper extremities. After a few months, you go and see patient's respiratory muscles will be paralyzed. After few minutes, patient's lower limb will be paralyzed. So, cranial nerves. From the cranial nerves, the paralysis will come down to upper extremity. From upper extremity down to the respiratory muscles. Dr. Sambhav has already told me the answer. You're perfect. Down it will come to lower extremities. So this paralysis is descending. Such paralysis is called as descending paralysis. Where do you see? I see in case of Clostridium botulinum. But in case of Guillain-Barré syndrome, Guillain-Barré syndrome, the paralysis will be opposite, ascending. The paralysis will start in the lower limbs. Slowly it will progress up to the pelvis, the abdomen, the respiratory muscles and the upper extremities. So, ascending paralysis. Keep this thing in mind, guys. Very, very, very important. Very, very, very important point, guys. Very, very important point. Okay. Now, after having this discussion, let us discuss the symptoms and the treatment part. We are done. Then we shall close this, take a break. Now, coming to the symptoms. First important symptom. What will be the first important symptom? Can anyone tell me? What will be the first important symptom of a classic type of this one, botulism? Abdi Nasir? No? Pain first. You know, life is pain. Life is really painful. Pain is present in every disease. But what is the first symptom here? Muscle relax? No. So what will be the symptom? Look here. The first symptom is that I told you in the starting of the pathogenesis itself, Jayanti, perfect. The perfect Jayanti is right. So I told you in the starting is that patient will take the toxin inside. It will damage the intestine here. It will damage the intestinal mucosa. So when intestinal mucosa, when the gastric rugae are damaged, the surface area of absorption will decrease. So when the surface area of absorption will decrease, patient will come with gastrointestinal upset because of this exotoxin. Okay. After that, when it will enter into the muscles, then the problems start. It will even affect your eye muscles. You know, it will even affect your eyeball muscles. You know, you have got some very beautiful muscles like superior rectus, inferior rectus, medial rectus, lateral rectus, superior oblique, inferior oblique. Sir, can you write down these names? I'll write when I teach you anatomy. Okay. So these are the eyeball muscles. So when patient eyeball muscles are not properly contracted, right, this would lead to a condition called diplopia. Diplopia is also called as double vision, right? So you can see two girlfriends, you can see your two boyfriends, you can see all the things in double. Okay, right. Next important thing, patient jaw muscles also will be affected. Very good, Osama. Double vision, perfect. Patient jaw muscles also will be affected, and patient cannot talk properly, right? Buccal muscles will be affected. He cannot talk properly, right? And this is called as dysarthria. Dysarthria, right? Another MCQ. Dysarthria is seen in Clostridium botulism. Okay, but the opposite of dysarthria will be rhizus sartorius. Dysarthria is your muscles don't work. Rhizus sartorius, your muscles of the mouth overwork. That would lead to rhizus sartorius. Keep that thing in mind. Okay, keep that differentiation in mind. Third important thing is that, you know, even your entire intestine is lined by smooth muscles. So when this toxin sits on the smooth muscles, do you think it will let the smooth muscles to contract? No. If smooth muscles are not getting contracted, do you think the food can propagate forward? Can there be peristalsis? No. So there will be problems with the problems with eating the food, problems with digesting the food. So patient will have dysphagia. Dysphagia. And respiratory muscles, if it will affect, it will lead to dyspnea. Dyspnea. Okay. Respiratory muscles will lead to dyspnea. So all these are the 4 Ds. All these are the 4 Ds of Clostridium botulinum. Clostridium botulinum. Distension, constipation. Yes, I will also tell that thing. But constipation is not common in adults. Look here. Facial weakness. Now I'll keep on writing and going, guys, because you understood everything now. Why facial weakness also you know now. Next, here also I have got muscle. This is called as superior palpebral muscle. That will also droop down. You know, when you also know anatomy along with other subjects, it's really interesting, right? You can, everything you can talk in anatomical language. Right. So drooping eyelids or drooling eyelids. Okay. So look here, guys. Look here, look here, look here. This baby which you can see here, this baby which you can see here, he is not actually sleeping. Rather, this is also called as a floppy baby syndrome. What is this? Floppy baby syndrome. Okay, floppy baby syndrome. Clear? Next important thing. Very good, Jilan. Jilan, very good, very good, very good. Oh God. I don't have this. Okay, fine. No worries. No worries. I don't have the picture, but it's okay. Fine. No problem. Floppy baby syndrome. But when it comes to children, when it comes to the neonates, what will be the symptoms? In adults, you just need to remember 4 important symptoms, 4 Ds for adults. Okay. But for neonates, look here. You feed the neonates. There is no peristalsis. So all the defecated material will stay there, right? And that would lead to constipation. Mother will complain that, doctor, my child was born in your hospital and I have been feeding in the hospital, and later on you have discharged us. I went back to home and still I started to feed. He's eating very nicely. I mean, he's having milk very nicely, but still is not defecating. Why? Because your child is in a constipated state due to Clostridium botulism, right? Obviously, the baby will be drooling, drooping, floppy. Okay. Mother also will complain that, doctor, everything was fine today, but a few weeks back, I have given milk to my baby. He drank it very much, but now he's not able to drink. He's not even sucking. No, yes, he won't suck because there is poor sucking ability. Why poor sucking ability? Because his muscles have been paralyzed. Okay. Right. We are coming to an end of the topic now. Is this Clostridium botulinum good for you or bad for you? Tell me. Is this Clostridium botulinum causing muscle paralysis? Is it good or bad? No, very good. Good and bad. Good in old female. So that she don't trouble you, right? Injections, Vaibhav is saying you're right. Vanilla already told me the answer. Botox injections, right? Look here, guys. 1, 2, 1, 2, 3. Both ways. I think Osama doesn't have any girlfriend. If you have a girlfriend, it would be better to give her. You will tell me, I think. Yeah? Right. But anyways, so the first important thing, if anyone is having any kind of muscle spasm, to relax that muscle spasm, I give this Botox injection. So to relax that, I give this Botox injection. When I give Botox injection, the muscle spasm gets relaxed. Second important thing is, there is a condition here. There is a condition. Look here. This is my esophagus. This is my stomach over here, right? The lower part of the esophagus has got a sphincter. The lower part of the esophagus has got a sphincter, and this sphincter is called as lower esophageal sphincter. The lower esophageal sphincter will contract, it will relax, it will contract, it will relax. But if the lower esophageal sphincter contracts continuously, then what will happen? The food, whatever you have taken from the esophagus, do you think will it go down? It won't go down. So when it won't go down, you know what will happen? The entire esophagus looks like this, swollen, because there's a lot of food within the esophagus. And this condition, you call it as achalasia cardia. Achalasia cardia. Now in this condition, exactly near the lower esophageal sphincter, if I give an injection of Botox, the muscle will relax, the food will pass down. So it is also useful in that. Okay, look here, guys. This is the barium scan. Okay, barium scan of the esophagus. You see, from here the esophagus was normal, it was completely normal, but it is dilated. You see, esophagus is dilated. Why? Because there is a lot of food, and it is constricted here. Why? Because the lower esophageal sphincter constricted there. Okay, barium swallow. Muhammad Yasir, you are perfect. Osama Sheikh, Dr. Benedict, all of you are excellent people. You already answered telling that it is a bird beak appearance. But I don't want to go in detail, guys, because this is micro lecture. We are going into, I mean, obviously it is worth discussing because they might ask you a question and put up this barium swallow X-ray. Okay. But yeah, even for rectal fissures also, it looks like a bird beak. Yes, Kartoff. It lasts for about 2 to 3 months. Again, you have to take injections. You know, right. Third important thing is the esophagus becomes like this. Now, don't think that the esophagus has turned into a very beautiful shape because at some parts of the esophagus there is spasm. Okay, this is called as diffuse esophageal spasm because esophagus has been contracted diffusely. See, this is diffuse esophageal spasm. Even for this condition also, you can give the patient Botox injection. Yes, Vaibhav is saying varicose shape. You call it as a varicose shape. Varicose, like a snake, right? You meant that one only, right, Vaibhavi? Varicose is snake. See, guys, many things, you know, corkscrew, varicose, snake-like, you know, many things you can frame it, right? So immediately what should I give? Now, first important thing, and this is a very serious condition, right? The first important thing will always be pray to God. Okay. The second important thing what you can do is that if it is less than 1-year-old child, then you need to give antitoxin. Now, what is that antitoxin? You give bivalent antitoxin. What is that? You give bivalent human antitoxin. Right? More than 1 year, all of us are equal. So you give equine derived antitoxin. Equine derived antitoxin, right? You understood, guys? Yeah. Now, if you remembered all these things or no, that doesn't matter. But before going to the exam, you just have to remember the differences between Clostridium tetani and Clostridium botulism. What are the differences? The first difference, the toxin here is tetanospasmin, and the toxin here will be Clostridium botulinum. Now you will answer Clostridium botulinum, I will answer Clostridium tetani. Second one, in both of them, what proteins are damaged? Snare proteins. Snare proteins are damaged in both of them. Okay. Third important thing, Shweta N, perfect. That is botulinum exotoxin. You know, actually I forgot the name botulinum exotoxin. That's why I asked you, right? Another important thing is that here, third point is that, what is the third point? Third point is that it prevents what? Release of which neurotransmitter? Inhibitory neurotransmitter. Prevents release of GABA or glycine. Okay, here prevents the release of acetylcholine, that is the activatory neurotransmitter, okay, or excitatory neurotransmitter. So yes, Vaibhavi, thank you for reminding me. The fourth important thing is about the paralysis. The paralysis here will be spastic paralysis, and the paralysis here will be flaccid paralysis. Flaccid paralysis, and don't forget it is also called as descending or ascending. Yeah, what kind of paralysis? Descending or ascending? Perfect, 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 perfect. Descending paralysis. Excellent, guys. Shall we do the questions now? Are you ready to do the questions with me? Right? So is there any image left that I haven't shown you? No. Shall we do the questions? Yeah. Let's do the questions now. Cool. A 45-year-old Caucasian male presents complaining of inability to open his mouth. He is not able to open his mouth. Maybe there can be lockjaw, I think, whatever it is. Maybe lockjaw also, I cannot open my mouth, right? Patient history reveals that he recently injured his foot from an exposed floor nail in his house. So there was an injury. Again the same thing. Again the same thing, right? The patient's symptoms are likely the result of, yeah, come on. You need to keep in mind one very important thing. He is not able to open his mouth, right? It means no matter how much he contracted his muscles, he is not able to open his mouth. Okay, no matter how much he has contracted his muscles, he is not able to open his mouth. It means his muscles have been paralyzed, which means there is impaired neuron release. Very good, very good, right? Excellent, excellent, excellent. Look at this question. A 9-month-old baby boy is brought to his pediatrician due to 9-month-old, keep it in mind, poor feeding and fewer bowel movements. Okay. His father notes that he has been less active and is having difficulty with moves. Vital signs are normal. Physical examination is notable for weak sucking reflex. He is not able to suck the milk. Ptosis. You know what is ptosis? Drooping of eyelids. See, this is called ptosis. Drooping of eyelid is called ptosis. Decreased eye movements. Okay. The results of the stool studies return several days later and show gram-positive anaerobic rods. The toxin, what is the toxin here? Very good. What will be the answer? Inhibition of neurotransmitter release. What neurotransmitter release? Can anyone answer? Very good. Dr. Farhat Nazin is telling me that it is floppy baby syndrome. You're perfect. You're right. Right? Acetylcholine, guys. Very good. Very good. Acetylcholine. Excellent. Very good. Look at the next question. A 24-year-old college student consumed a container of canned vegetables for dinner. Okay. 14 hours later. How many hours later? 14 hours later. What was the time I told you? 12 to 36 hours. So 14 hours later, he presents to the ear complaining of difficulty swallowing. Difficulty swallowing means dysphagia. Double vision. Again D. I told you to remember 4 Ds. Already 2 Ds are given with a history of canned food. So what will be the answer? Is it an obligate aerobe? Is it a gram negative? It is a rod shaped, non-spore forming or cocci shaped? It is a spore forming bacteria. So this answer will be wrong. It is not a cocci shaped, it is rod shaped. It is not an aerobe, it is anaerobe. It is not gram negative, it is gram positive. So the answer will be rod shaped. Excellent, guys. Perfect, perfect, perfect. Osama Sheikh, yes, you are right. Dr. Farhat. Gideon Riyami, your answer is right, Gideon. Very good. Excellent. Look at this question. A 3-month-old infant is brought to the ER by his parents. They state that the child had not had a bowel movement. No bowel movement. No bowel movement means diarrhea or constipation. Constipation. Right? So constipation. Constipation. Okay. In several days, and they are having trouble feeding the child. The physical examines the physical examines the child. The physician, I'm sorry. The physician examines the child and notices that the child appears less active. Which of the following is most likely to discovered during the patient's food history? What is the age? 3-month old. Food history. Food history. So what has he ingested? Yes, Roy, you are right. You are right here. He was telling the answer can be GABA. Yes, even I rectified my mistake. It would be GABA because he is not opening the mouth, right? He's GABA. But anyways, you understood the concept, right? That would be fine. Right. So what will be the answer? Very good. Excellent. Raw honey. Recent consumption of honey. Recent consumption of honey. That is raw honey. Okay. Raw honey. Perfect, guys. Perfect. Uh, Before I take a break for 5 minutes, and then I shall discuss Helicobacter pylori, guys. Okay. Helicobacter pylori. But please tell me, Helicobacter pylori, I won't take much time. Okay. We will discuss all the important points like this before, fastly, and then we shall do few questions like this. Few questions are there for Helicobacter pylori. We shall do this. Okay, and close the session. But guys, please tell me, did you understand these two topics? Because why I'm asking you and again, because many questions they will ask you from microbiology, guys. Many questions will be framed. I have completely told you, I've completely taught you clinically oriented, right? I don't want you to mug it up. I don't like to mug it up. I don't want you to also mug it up, guys. All of you to learn conceptually, right? So let us take a break. Let us take a break for 5 minutes, okay? For 5 minutes, 5 to 6 minutes. So even you guys fresh up and come so that we can start with Helicobacter pylori, guys. Thank you so much. Hello guys, so welcome back. Welcome back guys. Welcome back. Welcome back. Hi, hi, hi. Thank you. Right. The session has not yet completed. Sorry. Right. Let's start now. Let's start. Let's start. We are discussing United videos. Yes, I have recorded all my microbiology lectures. I have recorded all my pediatrics lectures. I even teach pediatrics. I have recorded all the pediatrics lectures. I've recorded all the clinical videos. I'm recording currently all the anatomy, and everything will be in the app, and app is going to release soon. Immediately when it will be released in the Telegram group, I'll update it. Okay. Thank you. Thank you. Thank you so much. Right. Right. So Vanilla GMC, I think you are from Guntur Medical College, right? Am I right? So we are about to discuss Guntur Medical College. Wow, fine. Uh, Helicobacter pylori, right? So we are about to discuss Helicobacter pylori. Thank you so much, United Videos. Right. So again, we shall discuss the details first. Okay, we shall discuss the details first, like we did before. So what were the details? This bacteria is a gram negative bacteria. Gram negative bacteria. And if you look at this bacteria, the shape of this bacteria is like this. The shape of this bacteria is like this with a flagella down. So this looks like a comma shaped bacteria or spiral bacteria. Okay. So the shape is spiral or comma shaped bacteria. Spiral or the comma shaped bacteria, right? Now, what are the important things? What are the important things you have to remember is that this bacteria has an ability to release an enzyme called urease. An enzyme called urease. So what is the function of urease, guys? The function of urease is that it would convert urea into what? It would convert urea into ammonia plus carbon dioxide. So why did you write the reaction? This reaction is very, very important. Clinically, how to relate this, I'll tell you. Okay. So ammonia plus carbon dioxide. So it is called as urease positive organism. This bacteria also releases an enzyme called as catalase. So if it is releasing an enzyme called as catalase, this organism will also be catalase positive. Okay. I have already told you the lecture, we shall finish it immediately within 15 minutes, 15-20 minutes. Okay. Right. So catalase positive. What is the use of catalase, guys? Catalase converts hydrogen peroxide H2O2 into water plus half mole of oxygen. Yeah, that's why the urease breath test is used. I'll tell you. I'll tell you the clinical relation with this. And this also releases another important enzyme that is called as cytochrome oxidase. Cytochrome oxidase. That is the reason why it is oxidase positive. Oxidase positive. Okay. So there are three functions: urease positive, oxidase positive, and catalase positive. So, and obviously this is a flagellated organism, and remember one thing, this is a non-sporing bacteria, right? It does not release spores. Okay, it is a non-sporing. Now let us directly enter into the pathogenesis. But before we discuss the pathogenesis, yesterday in the live lecture, I have told you What method of staining do you use for H. pylori? Anyone? Answer fast. Yes? Yesterday in the class, I have already told you that we use some salts called as silver impregnation salts, right? Silver impregnation method. Very good. Yes, Dr. Farhat, this is my second live lecture for micro. Yesterday was the first. There I discussed all the basics. This is the second. Okay. So that stain is called as very good, Warthin starry stain. Warthin starry stain. Warthin starry stain. I will also show you how does Warthin starry stain looks. But before that, let us fastly brush up the pathogenesis part. Okay. Then I'll show you the Warthin starry and then we shall end up the session and continue it tomorrow. Right. So if you look, H. Bacter pylori, all of you know it will cause gastric ulcers, right? So how it is causing, we'll see. This is your stomach. Okay. This is your stomach. Now, lining of your stomach, you have got some things called as gastric rugae. These are called as gastric rugae. So what are these called? These are called as gastric. All of you sit back and relax. Gastric rugae. Don't write anything. Now, what I'm telling is that I'm taking one gastric rugae and I'm drawing it here. And by the way, you should also remember one thing, that you even have these gastric rugae in the duodenal part also. Okay. Now look here. I'm taking up one gastric rugae like this. So this will be one gastric rugae which have been taken down. Okay. Now lining these gastric rugae, you have got the epithelial cells. You have got the epithelial cells. Some cells of these, some cells in between these epithelial cells are called as blue colored cells. What are these blue colored cells? These blue colored cells, they start releasing mucus. They start releasing mucus, which is the first barrier of your stomach, which protects from the acidic nature. Okay. So this is the mucus. And these cells which are releasing the mucus, they are called as foveolar cells. What are they called as? They are called as foveolar cells. Now, this rugae have got depressions inside, elevations, depressions and elevations. So this depression, whatever you can see, this is called as gastric pit. Gastric pit. Within this gastric pit, you have got some specific cells like this. Now these cells which I've drawn with orange, these are called as parietal cells. Parietal cells. Okay, these are called as parietal cells. Excellent, Roy. These are called as parietal cells. Now, another group of cells which are located deep down into the pit, these are called as chief cells. These are called as chief cells. And finally, we have got another cell here. This cell is called as enterochromaffin cell. Enterochromaffin cell. Enterochromaffin cell. Okay, keep this thing in mind. Now look at another important thing. I'm going to draw central nervous system. This is your central nervous system. Okay. Next, down here, what I will draw is that I already told you we have got gastric rugae in the duodenum also, right? So what I'm doing is that I'm just drawing one gastric rugae from the duodenum part also. Okay. But in this gastric rugae, you have got two different types of cells. Now, one cell is called as G cell. Okay. And other cell is called as D cell. G stands for gastrin cell. D stands for what? What is D? It also releases what? Somatostatin, or D is also standing for delta cells. Okay. G cell and delta cells. Okay. Next important thing, let me write up all these things and then explain you clearly, guys. Next important thing is that, guys, we have got spinal cord like this. Now from the spinal cord, we come across some neurons like this. So these neurons which are coming from the cranial part, from the sacral part, are called as craniosacral outflow or parasympathetic neurons. These are called as PNS, parasympathetic neurons. Clear? Now look here. These parasympathetic neurons, they innervate two different types of cells. These parasympathetic neurons, they innervate parietal cells. These parasympathetic neurons, they innervate enterochromaffin cells. Okay, now till here, did you understand? Very fastly tell me so that I will enter into the topic now. Yeah. Everyone, everyone, Shweta and Dr. Farhat, Roy, Vanilla, United Videos, all of you understood? Very good. Very good. Roy is going much more deeper. Is telling GVE, yes, from the GVE cells itself. Very good. Nescafe milk. Thank you. Thank you. Right. Dishang Patel. Thank you. Right. Now look here, guys. Important thing is that your parietal cells. Okay. Whenever you eat food, that food enters into your stomach. Whenever there is food in the stomach, you have to digest it. To digest it, you need HCl, and HCl is released by these parietal cells. So parietal cells will release HCl, hydrochloric acid. And another important thing is that enterochromaffin cells release histamine. What does they release? Histamine. Okay, and what will histamine do? Now don't hello Mukesh, hello. Right. What does histamine do? Histamine will activate your parietal cells. When histamine will activate your parietal cells again release HCl. This is an indirect way. Direct way is directly parietal cells, if you are activating them, they release HCl. That is a direct pathway. Okay, why are you telling this? Why am I telling you this is that, for example, by chance, if there is excess amount of acid within your stomach, excess amount of acid, let us say the parietal cells are overactivated. Let us say for some reason, the parietal cells are overactivated. When they are overactivated, they release lots and lots of HCl. When they release lots and lots of HCl, the acidic environment will be more. The pH will be too less, right? So in that condition, what can happen? There can be ulcers formed within your stomach. There can be ulceration within your stomach. To prevent that ulceration, what will happen is that, look here very carefully, excess amount of HCl will come down. The moment excess amount of HCl will come down, it will activate the delta cells. It will activate which cells? The delta cells. Excess HCl is coming down and activating delta cells. And what does this delta cells do? Delta cells will release somatostatin. And what does this somatostatin do? This somatostatin will go and inhibit the parasympathetic nerves. When parasympathetic nerves are inhibited, one side histamine is not released and other side HCl is not released, because enterochromaffin cells are shut down, parietal cells are shut down. Then what will happen automatically? The level of acid will come down. This happens in you and me. But what happens in those patients where there is excess amount of H. pylori? Look here, now we are in the topic. Look here very carefully. This is H. pylori. H. pylori is coming inside, and this is H. pylori over here. Now H. pylori will release an enzyme called urease. It will release what? It will release an enzyme called urease. And what will urease do? Urease will convert urea into ammonia. And what is ammonia? Ammonia is an acid or alkali? Comment down. Ammonia is an acid or alkali, guys? Very good. Nescafe, very good. Roy, very good. Dr. Bentek, excellent. Ammonia is alkali. So what will happen is that the more the what will happen is that the more the H. pylori, the more urease it releases. The more urease it releases, excess amount of ammonia is released. So when excess amount of ammonia is right now within your stomach, it means your stomach pH has been increased. The stomach is completely alkaline. So when the stomach is completely alkaline, this alkaline fluid will pass down to the duodenum. So when this alkaline fluid is passing down till the duodenum, now within the duodenum, your G cells are activated. Previously, D cells which are sensitive to acid. Now G cells which are sensitive to alkaline. Now what will happen is that these G cells start releasing gastrin. And what does this gastrin do? This gastrin travels all the way like this. It travels all the way, and gastrin will activate like this, like this, like this, and gastrin will activate parietal cells. Gastrin will activate parietal cells. On the other hand, gastrin will also activate your parasympathetic system. So when parietal cells and parasympathetic system is activated, what will happen? Parietal cells will release lots and lots of HCl because there is excess alkali. Now what should happen is that parietal cells are releasing HCl, they are releasing, and finally electrical neutrality is maintained. But here, bacteria doesn't like electrical neutrality. Bacteria doesn't like a normal pH. Bacteria, what it will do is that it will still keep on releasing urease. So what will happen? More and more gastrin, more and more parietal cell activation, then more and more acid is released. Excess amount of acid is released right now. Continuous increase. Anushka saying good evening. Dr. Bentek, yes, you are right, Dr. Bentek. Continuous increase in HCl. So when there is continuous increase in HCl, what is happening? There will be ulceration. There will be ulcers formed within the within your stomach. Okay. So all of you know, stomach has got mucosa. The innermost layer is called mucosa. Surrounding the mucosa, you have got submucosa. Surrounding the mucosa, you have got submucosa, and surrounding this submucosa, you have got muscularis externa, and surrounding that, you have got serosa. Okay, look here now. Where are the blood vessels located? Blood vessels are located within the submucosa part. Within the submucosa, blood vessels are located. Now look what is going to happen. This is the rugae. Okay. If excess amount of acid is going to damage only the mucosa layer, this is called as erosion. If it damages only the mucosa layer, it is called as erosion. If it damages mucosa, submucosa, then you call it as ulceration. That is the reason why whenever patient will have only erosion, right, you won't see any blood coming out. But whenever the HCl will enter deep into submucosa and damage the blood vessel, then you call it as ulceration. You can see bleeding. If this HCl enters deep down and damages all layers, then you call it as perforation. This is the pathophysiology, guys. This is the pathophysiology. So let me write down the notes now. First important thing. H. pylori. Right? What does H. pylori do? It will cause increase in the level of HCl. H. pylori will cause increase in the level of HCl. H. pylori will not only cause peptic ulcer disease, and this entire story which I have told you, this disease is called as peptic ulcer disease, right? So it will cause peptic ulcer disease. Not only peptic ulcer disease, it will also cause MALT syndrome. MALT syndrome means MALT syndrome, that is mucosal associated lymphoid tissue syndrome. Okay. And third important thing is it would even cause gastric adenoma. Thank you, Nescafe. Thank you so much. Okay. Okay. A patient is coming to me telling that, doctor, I think I have a lot of bacteria within my body. Now, why are you telling this? The reason is, doctor, I have severe pain within my stomach. The pain is so bad that whenever I defecate, I will see dark blood coming out. Whenever I vomit also, I see blood coming out. Then I have a doubt, then I will start doing diagnosis. So what is the first diagnosis I will do? The first diagnosis I will do is that I won't do biopsy. I know biopsy is costly, but I won't do biopsy. The first thing I'll do is that Okay, you are telling me that you have a lot of bacteria in your body. Yes, yes, doctor. So let me do one thing. I will give you a solution to drink. Okay, you drink that solution, and later on, I will put a small pipe inside. Now, once you have drank that solution, if there is bacteria really inside, then the bacteria will release carbon dioxide, and this pipe, whatever I have kept inside, this pipe will detect that carbon dioxide. If more carbon dioxide is there, it means there is more bacteria right now in your body. And that solution the doctor has given is urea solution. If there is bacteria there, it will convert that urea which you have drank into ammonia plus carbon dioxide, and this carbon dioxide will be exhaled outside, which can be detected by that machine. And this test is called as urea breath test. Understood? You understood? Dabish Rayan, thank you so much. Thank you so much. This is called urea breath test. This is the first test which you do. Okay, you have done urea breath test, and the patient is telling, doctor, you done urea breath test. You are telling me carbon dioxide will come outside. Now, my friend is also a doctor. He also tells me every day that you take oxygen inside and carbon dioxide is released outside. What if you're talking about that carbon dioxide? What if the carbon dioxide is not coming from my stomach? Okay, fine. So, what you need to tell to the patient is that, okay, fine. So, I will do another test, and I will show you the bacteria with your eyes. And that test, what I'll do is that endoscopic biopsy. Endoscopic biopsy. I will put a pipe inside your stomach. I will take a piece of your stomach. Okay, that won't hurt you. I will take a piece of that stomach. Okay, I will take that piece, put it under a slide, and I will add a stain called as Warthin stari stain. I will add a stain called Warthin stari stain, and then I will call you. You can look under the microscope and see how clearly your bacteria has damaged your stomach. Okay, doctors, can you please show me? Yes, the stain has already come, and now I'm showing to the patient. I'm showing to the patient his biopsy. Look here, all of you. This is your gastric rugae. You see, this is your gastric rugae. This is your gastric rugae. Look, the gastric rugae, it actually has to be like this. But how is the gastric rugae? It is damaged here. It is damaged here, but this part is fine. Both sides it is damaged. So this condition, I call it as atrophy of the gastric rugae. What is this? Atrophy. Atrophy of gastric villi. Atrophy of gastric villi. Second important thing is that can you see those black color dots there? Can you see all these small black color dots? Yes, doctor, what is it? These black color dots are nothing but your bacteria there. Okay, so very important question. What are the endoscopic findings in a patient with H. pylori? The endoscopic findings are atrophy of gastric villi. Okay, atrophy of gastric villi. And this stain which I have kept in front of you, this is called as Warthin stari stain. Warthin stari stain. Okay, I don't want to talk about the treatment because treatment will include, yes, Roy, villus atrophy. Villus atrophy is the right answer, or atrophy of the villus, whatever it is. I don't want to talk about the treatment because you give basically triple therapy, quadruple therapy. Those all you'll discuss in medicine. Okay, this is microbiology. I don't want to discuss those things. So I think we are done with the topic. And what will be the patient symptoms, guys? Patient will complain, doctor, I have upper abdominal pain. Why upper abdominal pain? Because I have stomach here. Doctor, I also have bloating. Why bloating? Why feeling of gas? Because the bacteria is releasing carbon dioxide. The bacteria is releasing all the different types of gases there. Next, doctor, I feel as if my heart is burning. But you have to tell the patient it is not your heart, because your stomach is located just nearer to your heart. You feel like your heart is burning, but it is your stomach which is actually getting damaged. Let us do the questions now. I hope you're all clear with the concepts. Let us do the questions. Right. A 45-year-old woman Meenakshi, treatment is treatment will be told in the medicine part. Okay, this is microbiology. I know you find it interesting, but we shall discuss in the medicine only. Okay. A 45-year-old woman has a history of mild epigastric pain. Okay, mild epigastric pain, which seems to have gotten worse over the last month. So, epigastric pain means upper abdominal pain. Okay, so she is telling her pain gets worse and after eating food several hours after meal and is somewhat relieved over the counter antacids. The patient denies abnormal taste in her mouth and radiating pain. Okay, she denies bleeding. There is no bleeding. There is no anemia or unexplained weight loss. So, which of the following is the best step? What will you? Dabish Rehan, yes, I'll complete the whole syllabus. Yes. So, what will be the next step of management? Yeah. Will I directly do upper endoscopy? Patient is coming with a pain, he is really worried. Okay, come, I'll do an endoscopy and take a piece from your stomach. No, the patient will run away. First test, which one will I do? Yes, all of your answers are right. What is the first step? What is the answer? What is the answer? Very good, Meenakshi Chauhan. Very good, Dr. Farhat. Very good. The answer will be urea breath test. The answer will be urea breath test. Okay. Next important question. You're not answering. Did you all understand the concept, guys? Why aren't you all answering? You understood the concept, right? Everyone, please comment everyone now. Please, did you understand the concept? Okay, Dishang, no worries. No problem. Okay, fine then. Let us go for the next one. A 49-year-old male complains of abdominal discomfort that worsens following meals. Okay. A gastric biopsy revealed 2 centimeter gastric ulcer. 2 centimeter gastric ulcer. And immunohistochemical staining demonstrate presence of rod-shaped bacterium in the gastric mucosa. So, which of the following is used by the infiltrating pathogen to neutralize the gastric acidity? To neutralize the gastric acidity, to neutralize the pH, what did the organism release? Obviously, all of you know, the organism, again, it is fine, it is urease. Okay. Shweta, it is not flagella, it is urease. Osama Sheikh, the answer is not, yeah, you're right, Osama. Everyone is right. Cool. A 58-year-old woman has progressively worsening epigastric pain. Upper endoscopy showed a 4 mm duodenal ulcer. Biopsy specimens revealed mild gastritis with no evidence of malignancy. Histological evaluation of tissue showed infection with gram-negative bacilli. What is the most likely organism here? Yeah? Klebsiella. Klebsiella basically causes pneumonia. Right? The organism is Klebsiella pneumoniae. Okay, E. coli. E. coli is mainly responsible for causing urinary tract infections. Okay, Streptococcus pneumonia is again pneumonia. So the answer will be Helicobacter pylori. Helicobacter pylori. Right. Now, who will answer me this question? Most reliable method of diagnosing H. pylori infection. Most reliable method. Very good, Meenakshi. Very good, Dr. Farhat. Very good. Carbon urea breath. Endoscopy, no. Dr. Benedict. Most reliable method. Yes. Roy, what is the answer? Everyone answered it as A, but the answer is not A. The answer is endoscopy. Why endoscopy? Reliable means on which results can I tell that yes, this patient is having H. pylori. How will you tell? See, if someone told about you, right? Even if a trustworthy person talked, I mean, he was telling you some rumors about you, you will definitely believe because he is a trustworthy person. But if you see, that is the most reliable truth, right? Looking is the most reliable truth. Observing is the most reliable truth. So you are looking directly to the bacteria there. You are looking at a stain which shows damage to the gastric villi. That is the most reliable. Okay. So the reliable will be endoscope. I think we are done with all the questions. And yes, I understand, Dr. Shweta. The internet is lagging, I think. Yeah, I can understand you. Fine. So these questions of H. pylori which we have just done are asked from your PLAB exam. PLAB exam, right? And they were also asked in your FMG. FMG. Fine. Right. So anyways, we are done with all the questions. We are done with all the concepts which we have to. Yes, Dr. Farhat, all my lectures are available on YouTube. I have all the lives are recorded there. Okay. So, all of you guys, we have discussed 3 topics. In the next live will be of anatomy, and that will be of 1st and 2nd November, right? For all of those students who haven't watched my previous lectures on anatomy, I will ask them to please watch them because we will be continuing the topics on 1st and 2nd November. Okay, we shall discuss. Don't worry, Sumant Keshri, don't worry. The lecture will be recorded in the YouTube. You can watch it later on. So guys, have you all understood? And are you confident enough in all these 3 topics which we discussed today? Yeah. Yes, I'm watching it. Your feedback for all of those who commented, for all of those who attended the lecture, please. I want your feedback, guys. Tomorrow there is no session, Dabish. There were only 2 sessions which were given. Yesterday was 1 session and today was the 2nd session. Okay. The next session will be anatomy. After that, again micro. So in that way. Okay. Anatomy lower limb is recorded. It is already recorded. It is already on YouTube. Okay. You can watch it. Yeah. All of you understood, guys. All of you. Right. I will send these notes to the group. Okay. I will send these notes to the group, guys. Don't worry. I'm really happy that all of you understood the concepts, and I'm more happy because you all answered the questions before I read. That shows how well you understood the topic. That shows how well you understood the topic and how attentive you were in the class. Thank you so much, guys. Thank you so much. I think we are, yeah. Right, guys. So, all of you, good night. Have a happy night. Good dreams. Right? Goodbye.